So our last speaker of the session is Dr. Wong Tin Yao. Dr. Wong is an infectious disease specialist in private practice, and he's a part-time consultant of the Infectious Disease Center and the Department of Medicine and Geriatrics of Princess Margaret Hospital, where he helped to establish the anal neoplasia screening service for HIV-infected persons. And he is currently serving as an honorary consultant in infectious disease and infectious control for a number of private hospitals. He is currently a member of the Center of Health Protection Scientific Committee on Vector-borne diseases. He was the past president of the Hong Kong Society for Infectious Diseases from year 2016 to 2020, and he was elected as the board of directors of the International Anal Neoplasia Society in 2023. He was trained in UK, USA, and Canada for adult infectious diseases, sexual health, HPV-related anal neoplasia screening. And so the topic of today is the HPV-related anal cancer, key summary of the latest international recommendations on screening for all clinicians. Thank you, Dr. Wong.
Good morning. Thank you, Chairperson, for your kind introduction, and thank you, the organizer, for inviting me to give this talk to assemble the last but not least piece of the puzzle for HPV-related oncological manifestations. And as a matter of fact, now seems to be the most opportune time to talk about anal cancer, because in the past 2 or 3 years, there are randomized control trials for prevention and also international guidelines being issued, and try to summarize all this for you in this talk. And your conflict of interest. And in the coming 15 minutes or so, I'll go over the epidemiology, risk groups, and screening recommendations, and management of precancers and cancers for you. I just returned from the 9th International Anal Neoplasia Society Anal Scientific Meeting a few days ago from London, and I hope to pack as much information that I can update you in this talk. So I think we can draw a corollary to cervical cancer for the progression for AIN to cancer, and anal cancer actually is 90% related to HPV. And based on understanding of cervical cancer, and there's a cascade of progression from low-grade lesions, which comprises of AIN1, and high-grade to high-grade lesion, which comprises of AIN2 and 3. And in each step of the way, there are opportunity for clearance and regression. And it is in person with persistent infection who are prone to HPV-related precancerous lesions and subsequently cancers. And notable risk factors include smoking and immunosuppression of any kind, especially for patients who are infected with HIV and who can be at as much as 100 times the risk of normal populations. And mind you, now that HIV, they are very potent antiretrovirals, and many of these HIV-related malignancy are decreased in incidence after the antiretroviral. But anal cancer is an exception. We don't know why. And worldwide, anal cancer ranks just below cervical cancer in causing HPV-related cancers. Is more common universally in women than men. And data from USA show that anal cancer is the second most common HPV-related cancers in women after cervical cancers, and second most common after oropharyngeal cancers in men. The incidence rate of anal cancer has been rising at a rate of 2 to 3% annually over the past 5 decades. The same trend was observed in Hong Kong. Universally, women are more affected than men by 2 times. As we can see here, 2/3 of the anal cancer cases worldwide occur in women, but only 3% of the cases in women arise in those living with HIV. That means there are other risk factors causing HPV-related anal precancers or cancers in women. And so this is important, since if we only focus the early detection strategy on women with HIV, and that will limit our effort for the prevention. Several meta-analyses have also been published that help to clarify the risk stratification of high-risk population regarding the anal cancer incidence. These charts show very nicely that HIV-infected men who have sex with men are at the highest risk, followed by HIV-infected non-MSM and women. And there are two groups which also stands out. One is women with history of vulvar precancers and cancers, and also women who had solid organ transplant 10 years ago. Another risk group include people with other immunosuppression or other gynecological cancers. Apart from vulval cancer, cervical and CIN, and also prone women to cancers, but to a lesser extent. This is a time dimension showing the longer duration since last cervical CIN, the higher the chance of a lady having anal cancer. And anal cancer is not a consistent, and anal sex is not a consistent risk factor for AIN or anal cancers in women. And in an Australian study, it was found that wiping of the buttock from front to back after toileting is predictive of AIN in women. And it's probably due to auto-inoculation as a result of the close proximity of the perineum to anus in women. And cervical HPV-16 and anal HPV carriage are highly correlated in pool analysis. And this data we know for long. And the true turnaround moment in anal cancer prevention is the completion of this landmark anchor trial, which took place in the US across different multi-centers and over many years, and enrolling more than 10,000 patients who are HIV infected. And the rate of anal high-grade lesions is high among men and women in this cohort. And it was found that for patients 35 years or above who are HIV infected, treatment of anal high-grade lesions when compared to active monitoring is associated with 57% reduction in the progression to anal cancer. And this study was prematurely terminated because of the overwhelming benefit of treatment. These results and the risk stratification were crucial in development of current screening recommendations. The International Anal Neoplasia Society, which comprises of more than 600 members globally, has issued these consensus guidelines last year. It broadly categorized population into A and B classes. And for the A class, the incidence of anal cancer is more than 10-fold of the normal population, and they are at higher risk of having anal cancer. These include men who have sex with men or transgender women with HIV, women with HIV, and men who have sex with women with HIV, and men who have sex with men and transgender women not with HIV, and person with history of vulval high-grade lesion or cancers and solid organ transplant. And for men with HIV, they are the age initiation for screening will be age 35. For others will be 45, and for vulval cancer patient will be within 1 year of diagnosis, and for organ transplant, irrespective of female or male, will be 10 years post-transplant. For other Class B population, the decision to screen will be a shared decision after the age of 45 with the patient. So for prevention of HPV-related malignancy, of course, the best measure, as the other speakers have talked about, would be HPV vaccination before sexual debut. And this vaccine is very potent, and it's very long-lasting effect. But in general population who are in adulthood now, many people are either unvaccinated or have been exposed to one or more types of the viruses already, and which makes them susceptible. And for secondary prevention, we targeted at screening for the anal high-grade lesions. So if untreated, the anal high-grade lesion progress at the rate of around 1 in 400 per year to anal cancer. That translates to around 10% in 5 years' time. So this is not something to be ignored. The human anus actually is around 5 cm long in men. I always told my patients around 2 segments of the finger. And is shorter in women, is around 4 cm. And the majority of the dysplasia actually occurs in this anal transitional zone at the squamous-columnar junction. This is embryologically actually is developed similarly to the surface. And early detection of anal cancer will impact patient prognosis. And suspicious symptoms, for example, rectal bleeding or sensation of anal mass or itching, should not be dismissed. And even, I think we should, as a clinician, inquire about such symptoms in people who are in high-risk categories. And visual inspection of the perineal region is important. And if cytology is to be taken, I usually will take the HPV typing as well in the same bottle of the thin preparation, and please do it if do it before the rectal examination, because the jelly that you use for the PR exam will interfere with the cytology result. And if cytology is taken, one should be prepared to do the high-resolution anoscopy for further delineation if there's any abnormalities. And colonoscopy is not designed to detect anal cancer because it has no magnification, and also the lesion is not stained up, so they are not easily visualized. So anal cytology is the most widely used and evaluated method for anal cancer screening. From meta-analysis, it demonstrates good sensitivity of around 81 to 85% for detecting anal precancerous lesions, but it has limited specificity, around 40 to 60% when compared to cervical cytology screening. But cytology generally perform better in immunosuppressed patients, for example, in patients who are transplant or HIV infected, because of the generally higher chance of having such lesions. And high-resolution anoscopy is an outpatient procedure with colposcope, and it used to examine the perianal region and the anal canal with special stain like acetic acid and glucose iodide. And this procedure has a very steep learning curve, and hence the bottleneck for anal cancer screening is usually HRA expertise availability worldwide. And our target, is to look for the whole SGJ in the anal canal. And the following are selected for some of the cases I saw over the years. This lady has a history of CIN 20 years ago and was treated. And she has also got SLD, and she was on low-dose azathioprine and prednisolone. And she was referred from a surgeon to me because on her hemorrhoidectomy, the surgical specimen found that there's a AIN2. And I performed the HRA for her, and the cytology come back to show low-grade lesion, but she had high-risk HPV-16. And the histology of these lesion show the presence of AIN2 with P16 block positivity. And this HIV man who has sex with men, 34 years old, is a chronic smoker, and he's diagnosed HIV 2019, and his lowest CD4 count was 310. He complained of PR bleeding, and hence he had a colonoscopy, and subsequently he was found to have an anal warty growth at the colonoscopy, and biopsy showed AIN2 with P16 block positivity. And I performed the HRA for him, which found this warty growth and another one in another quadrant. And both of them, they are AIN2 with block P16 positivity, which is regarded as high-grade lesions. And for information, usually for AIN2, if we also I will also ask the lab to do the P16, which is different from the serotype 16 of the HPV. And this one, if it is block positivity, meaning the whole strip is positive, it's indicate high-grade lesions. And this patient has no apparent risk factor. He's 48 years old, non-smoker, and he's HIV negative, and according to him, is purely heterosexual. He was referred to me from a surgeon for incidental finding of AIN on an anal polyp found at the colonoscopy. And I performed the HRA for him, and then the cytology was negative, and his HPV is negative, actually. But in the anal canal, there's a lesion there. Can you see it? It's like a warty growth. And the biopsy confirmed AIN2 plus HPV plus P16 focal positivity. So currently, several societies recommend screening in high-risk groups other than individuals living with HIV, such as women with history of vulval and high-grade lesion or cancers, and female transplant recipients. And most society recommend anal cytology with or without HPV testing as a screening test. And following the anchor trial, some of these guidelines also mention about treatment, but not all of them. In over 1,200 HIV-infected patients who are subjected to cytology or HPV testing, either alone or together, it was found that co-testing or combined triage improved the specificity and lower number of HRA referral. And so it's the recommended if the resources is feasible. So in the EN's guidelines, provision was also made for referral for HRA in places where facilities is not widely available for higher threshold of referral. as early as 2019, actually, the U.S. Transplant Society has already been recommending anal cancer screening and treatment for solid organ transplant recipients. And this is the workflow, one of the suggested workflow. And usually in people who are referred to me, I will do the high HPV typing, cytology, and also the anal rectal examination for them. If any one of these are abnormal, I will proceed to HRA. And so for HRA, if there's any suspicious lesions, I will biopsy them. And then if come back to be low grade, usually it can be observed, except if it's very asymptomatic. But if it's high grade, I will treat them. And if it's carcinoma, of course, they will be referred for oncology further treatment. And as far as treatment is concerned, there are several modalities. For topicals, one can use imicable, and which is an immunomodulating agent, and it has to be applied 3 times per week for around 3 to 4 months. And main side effect is irritation to the skin. And one can also apply 85% trichloroacidic acid to the lesions, like in cycles. And as far as ablative treatment is concerned, one can use Hypercator, which I use. It's like a trochlotary. Actually, this treatment is recommended by the National Institute of Health Office, ACE Research, 2014 recommendation. It's as a first-line approach to treatment. And other centers, some of them are using laser or cryotherapy. And mind you, HPV, anal precancers, they have a high chance of recurrence even after treatment. As high as around 50% of the cases will have recur in 2 years' time, because HPV is a field effect, because what you can see is only something prop up on the, and then there are underlying HPV infection on the mucosa as well. So to sum up, anal cancer is rising in incidence, and early detection will improve the prognosis, and screening for high-grade lesions and its treatment was proven to reduce anal cancer in HIV-infected persons. And we have also got a lot of data for other risk groups, and so much so that international guidelines have been formulated, and it will be interesting to see how these will evolve to change the standard of practice in the years to come. And we need to expand the training for HRA and its availability. But even before that, we have to remember to do the digital exam for all patients and inquire about their symptoms, even if we are not doing this anal cytology and HRA. And it is a preventable disease. Thank you very much for your attention.